Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing fluids, vasoactive agents, and shock syndromes, including hypovolemic shock, distributive shock, and cardiogenic shock. Our objectives for today will be to characterize the characteristics of hypovolemic distributive shock, primarily sepsis/septic shock, as well as cardiogenic shock. We're going to describe the characteristics of vasoactive agents and crystalloids and colloid solutions, review water distribution in the body as it relates to crystalloid solutions, and a little bit with the colloid solutions, discuss the literature comparing crystalloid and colloid solutions, identify etiologies of cardiogenic shock, and develop a therapeutic plan to manage cardiogenic shock. So we'll first start off with hypovolemic shock and fluids. In regards to shock, there are actually four different kinds of shock. There are hypovolemic, distributive, cardiogenic, and obstructive. Usually, hypovolemic, distributive, and cardiogenic are the three most common types of shock. As my residency program director and preceptor once taught me, whenever you think about shock, you have to think of it in a few different ways. Is it a volume problem? Is it a pump problem? Or is it a vascular tone problem? Volume problem obviously relates to it being a hypovolemic shock. Pump problem, basically our heart is our pump, and in that case, if we have a pump problem, like ventricular failure, you can basically have cardiogenic shock. And then if you have basically a loss of vascular tone or vasodilation, you can have distributive shock. And there are many different types of distributive shock. The first shock that we're going to specifically talk about is hypovolemic. And keep in mind that we're going to mainly focus on hypovolemic, distributive, and cardiogenic for the purposes of this talk today. Obstructive shock is not as common. It is a result of an obstruction in the vascular system. Usually that will cause hypotension because blood is not able to flow forward. And that's basically what you see here. The way that is treated routinely is through alteplase or TPA. Going with hypovolemic shock first, the incidence of hypovolemic shock is unknown. And basically, a lot of times, hypovolemic shock can be unintentional, whether it be through accidental purposes, such as a trauma, where a massive amount of bleeding occurs, or even in cases of dehydration, where patients may lose a lot of volume in their bodies. And remember that our blood pressure is governed by cardiac output and systemic vascular resistance. Our cardiac output specifically is a function of heart rate and stroke volume. So if you basically deplete the volume, or in this case, the stroke volume in that equation, you're going to basically deplete blood pressure. And that's basically where hypovolemic shock basically occurs. It's basically a loss of volume in the body somehow. Its kind of more formal definition is that hypovolemic shock is inadequate tissue perfusion resulting in circulatory failure. So basically this happens as a result of extracellular volume depletion. So it's either a loss of blood, where we may see massive amounts of blood loss because of trauma or some other type of cause like a GI bleed. We may have plasma loss. Plasma loss may be due to dehydration, for example. In addition, we may also have third spacing. Third spacing, remember, is whenever your body basically shifts fluids to areas where they are not always traditionally found. So we typically think about our fluids typically being in the intravascular space within the bloodstream. But whenever we have fluids that basically shift to other areas like our peritoneal space in our abdomen, you may get third spacing. And this happens for a variety of different reasons. One of the main ones is cirrhosis. So when patients are very low on albumin in their bodies, as a result of not being able to make it with cirrhosis, that bodily fluid actually leaks out from the vascular space and into the interstitial space. And if your body fluid is not in your vascular space, in that case, that fluid going to the interstitial space will actually drop your blood pressure. And that is basically how third spacing can result in volume depletion. It's primarily found with cirrhosis, but it can also be found with other disease states as well. So we have to keep in mind what we're actually losing, and is it a real loss, or do things just need to be pulled back to the intravascular space? And we basically have therapeutics, not only just pharmacotherapeutics, but also blood products that can help replace some of these losses, in addition to pharmacological agents. In terms of the etiology of hypovolemic shock, like we talked about, it can be internal fluid loss. And that internal fluid loss can lead to a decreased oncotic pressure. If you remember oncotic pressure is like the magnet pressure that basically draws fluid into the intravascular space. That is basically the pressure that we want. It could also come from cerebral, chest, or abdominal sources. So say if, a patient, develops a brain bleed or a GI bleed, for example, that can actually result in internal fluid loss. You might have fluid accumulation in the bowel, the peritoneal space, or the pleural cavities, kind of like what we talked about earlier with third spacing. And whenever you third space, you lose that volume in the bloodstream. Long bone fractures can also be a result of internal fluid loss, and we see this in trauma patients. You can also have external fluid loss as well, such that you may see it with patients who are over-diuresing or urinating too much. Typically with over-urination or over-diuresis, that can basically result from pharmacological meds, such as loop diuretics, for example, but it could also result from disease states as well, such as DKA, where we over-diurese patients, or basically patients over-diurese on their own because of DKA. You might have external fluid loss from the GI tract, such as nausea, vomiting. You might have diarrhea occur, fistulas, which are basically little openings that basically leak out fluid and protein, for example. You may have external fluid losses from the lungs, and you might actually have external fluid losses from the skin too, whenever patients may sweat or they might have a burn. Patients lose lots and lots of fluid sometimes if the burns are major burns. This slide shows a little bit in terms of the pathophysiology and the pathway of hypovolemic shock specifically. Normally, patients have a normal circulatory function and normal hemodynamics, so blood pressure is usually normal, and we don't really have a lot of acute issues with most patients. However, whenever patients have their plasma volume depleted or other volumes depleted in their body, then you basically don't have enough blood flow that can flow to all of the vital organs. Then at that point, your body will start prioritizing things. It will start prioritizing your most important organs, which it considers to be the brain and the heart. And whenever you prioritize the brain and the heart, all of the other organs will basically, be fighting for whatever is left. One organ specifically, the kidneys, typically get about 25% of our cardiac output from the heart, or basically the amount of blood flow from the heart. And whenever you don't have blood flow to the kidneys, then that basically can result in AKI, or acute kidney injury and kidney damage. The other organs also take a little bit of a hit also, such as your liver, your gut. Many other different organs are basically taking hits here, and it's not good. You ideally want to, restore whatever fluid or volume was lost, or else you're going to basically keep going into this prolonged ischemic injury. And the longer that it lasts, basically, the more damage is done, all the way up until the point where you might have long-term complications and then eventually death. And that's basically what this slide is summarizing. In regards to presentation, usually patients that come in with shock are going to have arterial hypotension. And usually most of the time in practice, that is considered to be an SBP or systolic blood pressure less than 90 or a mean arterial pressure less than 65. And mean arterial pressure is calculated as 1/3 of the systolic blood pressure plus 2/3 of the diastolic. In addition, with hypovolemic shock, you might see a lot of different other presentations, such as patients that have tachycardia. And tachycardia is usually a stress response But in the case where we have hypovolemic shock, because the volume of the body is lower, the stroke volume is decreased, what happens is your heart rate increases because heart rate and stroke volume are inversely related. You also might get tachypnea because your patients are not having as much blood flow to all of your vital organs. And as a result, that blood is actually carrying your oxygen around to different parts of the body. So it's very, very important that you treat this early because you can have many different organ dysfunctions as a result of shock. Thirst obviously is a big one. Nausea can happen because whenever you don't get enough blood flow to your gut, then at that point you start becoming nauseous. Your gut is very much supplied by blood also. And whenever you start feeding that gut and that gut is not basically oxygenated very well and sick, then it will basically, not put up with anything that is basically put into it, such as food and liquids. You may get acute kidney injury, pre-renal azotemia, so you may get low urine output, less than 0.5 mils per kilo per hour. You might become oliguric or you might become anuric, depending on how long and how bad the actual injury is. Additionally, we may see patients that have dark yellow urine, and that's basically from the fact that not a lot of urine is actually probably being produced. And that there is not a lot of actual plasma volume there to basically dilute that urine to basically become more of a lighter yellow color. Patients may have altered mental status. Yes, the body will typically prioritize the brain, but there are still going to be some changes that are going on whenever you have less blood volume, and that can result in altered mental status, can result in orthostatic changes. If it lasts long enough, multi-organ failure, usually the kidneys getting hit first, but any organ can basically be hit, and many others in regards to hypovolemic shock. So it's very, very important that we try to replace those fluids that are lost very early in the process. How do we monitor hemodynamics? So typically we think about using a blood pressure monitor or sphygmomanometer to measure a patient's blood pressure. But because the blood pressure is low in shock many times, obviously, then at that point, your blood flow is not actually flowing to your arms. Remember, your blood is flowing to your brain and to your heart. And that's why these blood pressure cuffs or sphygmomanometers are not really reliable in shock. You're not going to necessarily hear a blood pressure. You're not going to hear a pulse, and they're basically unreliable. So usually what we want to do is invasive hemodynamic monitoring. We want to usually, with hypovolemic shock, measure a map and blood pressure with an arterial catheter or an A line. And these are lines that we talked about prior in the Intro to ICU or Intro to Critical Care lecture on day 1. Additionally, we might want to monitor other parameters like CVP using a central venous catheter. In addition, with that central venous catheter, as you know, we can also do many other things with that central venous catheter, such as give medications. Sometimes we even may use a pulmonary artery catheter or a PA catheter. A lot of times these are used in patients who are cardiogenic shock, but they can also provide ideas about how much volume is actually in the body through usage of basically measuring things like wedge pressures. How do we treat hypovolemic shock? So usually patients will be hospitalized and basically monitored in the hospital whenever they come into the emergency room. We're going to want to obtain venous access for fluid and medication administration. So usually a central venous catheter is going to be the way that we do this. So a subclavian, a femoral, a PICC line, an IJ, something that will basically allow us to basically give lots of fluids over shorter periods of time. We want to remember the ABCs and not necessarily just the general alphabet, but we want to watch the patient's airway. So basically making sure that they don't become too hypoxic or too tachypnic. We might have to intubate them. And that basically relates to breathing also. We also want to monitor their circulation. We might have to, not only just give fluids and blood products and other things to basically replace this patient, but we also might have to consider vasopressors after we've given them adequate volume resuscitation. And we still obviously want to monitor the vital signs, and we want to monitor other things like urine output to assess the patient's responsiveness to this volume. Is the blood pressure getting better? Is it getting worse, or is it basically staying the same? If we have patients that don't get any better with, increased volume being administered, such as they don't actually make a lot of urine output, then we might have to consider other modalities of treatment like dialysis if their urine output is just so poor even after giving them liters and liters and liters of fluids. What are some non-pharm things that we can do? So it really depends on the source of the hypovolemia. We talked a little bit earlier on the last slide about securing the airway in select patients who may need to be monitored for their oxygenation status. So this can be any of the oxygen modalities we talked about in the last class, including mechanical ventilation. We might also try to do a physical compression or surgery to contain blood loss. Remember, if you don't correct the underlying cause, the underlying disorder is not going to get better. So if your cause of hypovolemic shock is a trauma or a GI bleed, for example, you usually want to compress or basically minimize whatever the source is to treat your patient's hypovolemic shock. We want to stabilize any fractures that they might have. We might want to use cooling measures for patients who have extreme heat exposure or burns. And we want to do wound care for patients that have thermal injuries, because those injuries, until they get better, are going to keep basically leaking insensible loss and fluid as a result of that. And that's not obviously great in patients who are at risk or have hypovolemic shock. How do we treat hypovolemic shock pharmacologically and through blood products? Like we said earlier, we want to correct the underlying cause of the hypovolemia. So if it's dehydration, we might want to give crystalloid fluids. If we have patients who are coming in with trauma or large GI bleed, we might want to give them blood products, for example. So packed red blood cells usually are a big mainstay of replacement of blood products. Other things may be also depleted, like fresh frozen plasma or FFP. Fresh frozen plasma actually contains all of our different coagulation factors, like 2, 7, 9, and 10, for example. We might give platelets if platelets end up being super, super low. Typically in practice, we don't give platelets unless the platelet count is actually less than 10,000 or 10. If they are actively if they're not actively bleeding, and if they are actively bleeding, our threshold is usually 50. We might also give cryoprecipitate, which basically contains fibrinogen, to help patients also, because whenever you're losing blood, you're also losing all of those things, and the packed red blood cells basically just contain hemoglobin. So think about what the underlying cause is, and then treat appropriately with crystalloid or colloid solutions, or a combination of both. In regards to our crystalloid solutions, you know that we have many different crystalloid solutions, such as sodium chloride, 0.9% sodium chloride, or normal saline. Lactated ringers, these are the two that are used mostly for volume resuscitation in shock states. We also have 3% sodium chloride. We have dextrose containing solutions like D5W and D5-NS. Normal saline is probably the most common agent that's used for volume resuscitation out in practice. It's also known as 0.9% sodium chloride, or NS. It contains 154 milliequivalents per liter of sodium and 154 milliequivalents per liter of chloride. It's relatively cheap cost-wise. It only costs like maybe a few pennies to a few dollars in regards to the cost. So whenever you think about all the other treatments that you could give, like blood products and colloids and blood products may actually be a little bit more on the expensive side. Adverse effects that we may see from normal saline include hypernatremia because of its sodium content is 154 milliequivalents per liter, and our body is typically between 135 to 150. So if we're giving 154, you are what you infuse. So if you give 154, you are going to eventually get closer to that 154 in the body if you keep infusing lots of it. You also see more predominantly hyperchloremia also, and this hyperchloremia can lead to a hyperchloremic metabolic acidosis from the chloride load. And that chloride load can also contribute to acute kidney injury, though a lot of times in shock, it's going to be very, very minimal in regards to the patient's kidney injury being contributed by normal saline itself. Usually we'll still give normal saline to these patients, except in the cases where maybe their chloride load may be very high, where it may be super therapeutic, like greater than 105 or greater than 110, unless they have other clinical indications to basically get these more concentrated solutions like head traumas, where you might actually have to give hyper osmolar agents like 3%. Lactated ringers is the other main fluid we give for volume resuscitation in hypotension. It's also known as LR. It differs also in its composition in that it has less sodium, less chloride, 4 millicoints per liter of potassium, 3 of calcium, and 28 of lactate. So it actually mimics closer to what the body actually has. Relatively, it's cheap cost-wise. It is a little more expensive than normal saline, but still, in regards to comparison to cola, it's cheaper. Adverse effects that we're concerned about with lactated ringers is primarily hyperkalemia in patients who already have pre-existing kidney conditions like CKD, end-stage renal disease. Like I said with normal saline, if you have a patient that's in shock, then we can still give, lactated ringers to these patients, with, the idea that we're basically helping to treat their AKI by basically trying to replace their fluids and basically minimize the shock. But if you have a patient who has pre-existing, hyperkalemia, for example, it might not be the best agent for you to give, particularly in those patients who have renal dysfunction. So this basically kind of classifies the general crystalloid indications. These are not, it's not necessarily a full out, list of all indications that you would be able to give all crystalloids for. Usually though, we want to give what are known as isotonic fluids to patients that have intravascular depletion resulting in hypotension. So those are normal saline and lactated ringers. If you have patients who have certain types of head trauma where you basically need to minimize the amount of cerebral edema that patients may develop, we might use 3% in those cases because the 3% will actually draw fluid from the brain tissue into the vasculature. Additionally, we could use dextrose containing solutions. These are usually used in patients that have dehydration, primarily water loss, in patients with mild symptoms of volume depletion. So that mild symptoms or moderate symptoms mean that the patient is not hypotensive, usually. We don't want to give these types of fluids to patients who are hypotensive because they actually will not stay in the vasculature as much as a normal saline or lactated ringer solution would. Just to give you an idea of how that body water is actually broken out in the body, body water is split up into 1/3 extracellular in the body and 2/3 intracellular. So between the actual fluid that we have in our body, less of it is actually extracellular. And our extracellular compartments are basically our interstitial space in our plasma. And the part that actually governs our blood pressure is the plasma area, or the intravascular area is also what it can be labeled as well. And you see that in general, only 8% of this overall volume will actually contribute to this area if you have just a generalized fluid. Now, whenever you do have that generalized fluid, and the generalized fluid I was actually referring to in the last slide was 5% dextrose or D5W. Remember, you have 2/3 of it go to the intracellular space. And then the 1/3 will go to the extracellular spaces, which are your interstitial space, which makes up about 25%, and your intravascular space or your plasma space, which makes up only 8%. And that's basically how we kind of get these numbers that are here, versus the fluids of normal saline and lactated ringers. Because they are isotonic, these fluids will actually mix very well with what we have in our extracellular space, and they will not even go into the intracellular space. They won't even go into the cell. They will only stay extracellular. And between the interstitial space and the intravascular space, the normal saline and lactated ringers will basically split up in a 3-to-1 ratio. So basically 3 parts will go to the interstitial space and 1 part will go to the intravascular space, similar to the remainder of the fluid with the D5W that you see here. So as a result, for every liter of normal saline or lactated ringers that you give, you're actually getting 250 mils into that intravascular space, versus D5W you only get 83. Now with 5% dextrose and half normal saline, or 0.45% sodium chloride, you actually get 167. So it's a little bit of a midway between those two. So overall, not too great. That's why we usually will give normal saline and lactated ringers, because most of it goes into the intravascular space. And in hypovolemic shock and shock states where we need more volume, we're going to want to give the most volume that we can. And by giving 1 liter of normal saline or lactated ringers, it's much better than giving 1 liter of 5% dextrose. You'll get 3 times as much volume there. And you see that these numbers are bolded, so these are big hint stars for important concepts to know for your exam. In regards to the crystalloid solution components, like we mentioned before, normal saline and lactated ringers are isotonic. 5% dextrose is hypotonic, so it will go not only into the extracellular space, it will also go into the intracellular space also. Keep in mind that the components of these solutions are bolded, and these are important to know because they not only play a role in your treatment of shock, but they also play a role in the types of electrolyte disorders that you may actually get from some of these fluids, such as normal saline with hypernatremia and hyperchloremia. With 5% dextrose, you can actually get hyponatremia because there is no sodium in that particular solution. You can also get hypochloremia from the 5% dextrose also by giving lots and lots of it. So which crystalloid do you generally use? So there was a previous slide on this that we had discussed, but like we said before, for mild dehydration or in patients who are NPO or sometimes hypoglycemic, we want to use generally dextrose in water solutions, just in general. There may be exceptions to this in practice, and you may see different things in regards to this in practice, and that's okay. But just from mild dehydration that's caused by water deprivation, we want to use dextrose in water solutions. And dextrose in water is typically sometimes maybe referred to in some practices as free water. By giving dextrose, we're basically replacing water in our patients. But if you have a patient who's hypotensive as a result of hypovolemic shock, then you want to use the isotonic crystalloids because those will get more into the vasculature than our hypotonic solution like D5 or our hypertonic solution like the D5 half NS. Additionally, in addition to the crystalloid solutions, we also have colloid solutions. And the main one that we have out there is albumin. There used to be more wider use of hydroxyethyl starches in dextran, but they are not usually preferred anymore for a variety of different reasons. One particular reason for the dextran is it did have a lot of allergic reactions associated with it, and albumin has kind of become the mainstay now in terms of colloid solutions. So albumin is basically provided as a plasma protein, and it's provided in 5% and 25% concentrations. And this is kind of what it looks like here. It's this yellow fluid on the right. It's relatively more expensive cost-wise, and you might actually see a vial of this albumin, which is about 100 mils of 25%, go from anywhere from $30 to $60 a vial, versus the costs that I mentioned for normal saline and lactated ringers, which is like pennies to dollars compared to this. So usually, because of the cost and the general efficacy of albumin versus our patients who are getting crystalloids, albumin is just generally more expensive, and you'll usually have similar outcomes, which we'll talk about shortly. Some adverse effects that we're concerned about: it is a blood product in nature, so anaphylaxis can occur. And kind of going off the same route of thinking, if it's a blood product, you could potentially get infections from this. One other thing I want to just mention briefly about albumin is, because albumin is a blood product, you might have special considerations whenever you have patients who have certain religions or beliefs, like patients who are Jehovah's Witness patients who may not be able to get certain blood products. Some may be okay with albumin and some may not be okay with albumin. So it's always important to kind of be aware of religious status, if you are able to know about religious status or other statuses of patients, which may preclude usage of certain blood products or medications. The way that albumin works to fluid resuscitate a patient is best shown by this diagram. What albumin does is it will increase your oncotic pressure within the vasculature. So it will basically cause a reabsorption of fluid into the vasculature, similar to what you would see a little bit on the right, where basically you are drawing fluid in. And basically albumin will increase oncotic pressure, which is basically like a magnet. If you're increasing oncotic pressure, you're basically increasing your route to basically pull fluid into the vasculature. And that's what albumin does. So what are our indications for albumin? Depending on what you have on formulary at your different hospitals, albumin, like we said, comes in two different types, 5% and 25%. The more common type used in practice is 25%, but 5% can also be used. 5% can be used in acute hypovolemic states, and it basically has a similar, more or less kind of tonicity or basically pressure to what normal saline has. So for every 100 mils of the 5% albumin, you're actually, using about the same amount or getting about the same amount of response that you would get from 100 mils of normal saline. Simple enough, right? With 25% albumin, though, it's usually best used to pull fluids into intravascular spaces, though it can also be used in patients that have acute hypovolemic states. It shouldn't be used generally for that unless it's given, though, in combination with fluids. So usually what we want to do is, if you're fluid deprived, we want to give crystalloids first. And then if we've given enough crystalloids such that, the patient is not able to respond to crystalloids anymore, like they're not getting better blood pressure wise or having any other surrogate markers that are improving, then we can consider albumin if we have concern that the patient may be third spacing or may just need an additional bump. And in those cases, 25% albumin does really well with that if you're giving it with other fluids like normal saline or lactated ringers. But the 25%, about 500 mils of normal saline is more or less the equivalent of what 25% albumin is. So in regards to albumin, 25% is basically considered hyperoncotic. It does very, very well on a volume basis to increase your volume status. So should crystalloids or colloids be used for volume resuscitation? We talked a little bit about this and alluded to the fact that crystalloids probably are better just in general, but what's the data on that? So there was a landmark trial called the SAFE trial as a comparison of albumin and saline for fluid resuscitation in the ICU. And it compared 4% albumin, which is more or less very similar to 5% albumin, to normal saline. It was a double-blind randomized controlled trial. And what the outcomes were in this study that they looked at were mortality, survival time during the first 28 days, newly diagnosed organ failure, duration of mechanical ventilation, if the patient needed renal replacement therapy like dialysis, how long did that last, and duration of hospital and ICU length of stay. And this was published in the New England Journal all the way back in 2004. The study actually included close to 7,000 patients and about a 50-50 split. The only baseline characteristic statistically significant was the CVP between the albumin and the normal saline groups, which was 9 versus 8.6. Statistically significant, but it doesn't really look too clinically significant. 8.6 versus 9 is not too far off. All the other baseline characteristics were not statistically significant. What they saw actually in this study in regards to the primary and secondary outcomes was that there were no statistical differences between all of their outcomes. They didn't have any increased patients that died from a statistical significance perspective. In regards to organ failure, it wasn't statistically significant. Duration of mechanical ventilation, renal replacement therapy, length in the ICU, none of it was different between the albumin group and the saline group. So overall, what do you find with crystalloids and colloids? There was really no difference in outcomes between the crystalloids and colloids in the SAFE trial. So the only real difference that we have at this point in terms of, what we would think of in general, we think about efficacy and safety. So if we have efficacy and safety pretty much similar between the groups, at that point it's going to come down to cost. And because the crystalloid agents are pennies compared to the more expensive colloids like albumin, we are generally going to stick more with crystalloid fluids first line. If you have patients who are refractory to crystalloid fluids, such like where they're getting like fluids like more than 30 mils per kilo for their crystalloid fluids, then in those cases you might potentially consider colloids. There are also other indications for colloids as well, as we kind of mentioned. If a patient has third spacing, for example, it can pull fluid back into the vasculature, and sometimes it is helpful in patients who have liver disease or cirrhosis. So there are other potential indications, but in regards to just hypovolemic shock in general, we will basically, leave it at crystalloids first and colloids as an adjunct if you need it. So now that we talked about fluids, now we can talk about distributive shock and the vasoactive agents. So in regards to shock, distributive shock is basically a result of vasodilation from one or more etiologies. And that's actually what we see here. So we talked about hypovolemic shock, how hypovolemic shock was a volume problem. Distributive shock is a vascular tone problem. Distributive shock is shock resulting from the periphery, and it can be secondary to a release of inflammatory mediators, such as what we see with sepsis and with anaphylaxis, or it can be a result of injury, such as neurogenic injury, like where you might have brain injury or spinal cord injury. So all of these things can actually regulate your vascular tone. Inflammatory mediators can actually cause vasodilation in states such as sepsis and anaphylaxis. In regards to injury, another thing that governs vascular tone is basically our neuronal control of the vascular tone. So remember that we have our brain and spinal cord governing our system of neurons in the body, and basically, more or less our neuronal electrical system. If that neuronal system for some reason gets damaged, such as what we might see in a patient that has a spinal cord injury or certain types of spinal cord injury or other types of brain injury, then you might get a decrease in vascular tone because your body is no longer able to regulate it from the neuronal perspective. Those neurons can basically, tell the vasculature when it needs to constrict and when it needs to dilate. And if it's basically broken, it may basically resort to just dilation. And that can obviously decrease vascular tone, and that decreases systemic vascular resistance, where we get the hypotension, and increases peripheral vasodilation. Sepsis is the main type of distributive shock that we're going to talk about. It's probably the most common of these three. Anaphylactic shock and neurogenic shock are relatively rare, but they can still happen. So whenever we think distributive shock, if I basically say sepsis, sepsis is a type of distributive shock. But distributive shock as a term can relate to sepsis, anaphylaxis, or neurogenic shock. So in comparison of the different types of shock, we talked about hypovolemic earlier. So we basically have a volume component, a pump component, and a vascular tone component. Volume components for ourselves in terms of parameters that we look at are CVP and pulmonary artery occlusion pressure, or pulmonary wedge pressure, more or less, is also what PAOP is. In patients who have hypovolemic shock, the volume is going to be decreased. And because the volume is decreased, the cardiac output is decreased. To compensate for the decrease in cardiac output, we have a ramping up of systemic vascular resistance that happens. But it's not necessarily going to compensate for that full shock. In septic shock or distributive shock, you have basically two different types. You have the more common hyperdynamic, where the volume could be any which way. However, in a hyperdynamic patient, you're basically going to have a patient who is more along the lines of their systemic vascular resistance being low as a result of sepsis, usually, and the vasodilation that happens from sepsis. And as a result, your cardiac output is actually going to increase to compensate. In septic hypodynamic shock, this is a little bit more of a complicated type of shock where you actually have two things going on. You have basically sepsis, potentially with a cardiogenic component involved. And what I mean by a cardiogenic component is cardiogenic shock is just the decrease of cardiac output. And remember, blood pressure is governed by cardiac output and systemic vascular resistance. So if you have a low cardiac output, you're going to have a higher systemic vascular resistance because they are always opposite of each other. They are inversely related. And in cardiogenic shock, if you think of patients that have heart failure, the most common cause of cardiogenic shock, a lot of times they're going to have increased CVPs or wedge pressures because that fluid is not able to flow out appropriately, and they will basically have that fluid back up in their body. Now, with septic hypodynamic, which is a combination of septic and cardiogenic, you actually may have septic shock, but you also have a cardiogenic component, either from the fact that your patient may have a pre-existing heart failure, or the septic shock actually causes myocardial depression, where that patient is not able to pump out as properly as they would prior. And that basically kind of results in a similar phenomenon that you see with cardiogenic shock. The wedge pressure and the CVP can actually be either which way, though, in regards to the volume for that. So how do we treat distributive shock in general? We obviously want to treat the underlying cause of distributive shock when possible. So if it's septic shock or sepsis, we want to treat the patient by basically eradicating the infection, because that will minimize the inflammatory response that is causing the distributive shock, and as a result improve the blood pressure. In regards to blood pressure management alone, other than correcting the underlying cause with antimicrobials, we're also going to look at using fluids, including the crystalloid fluids and albumin. Additionally, we are going to consider vasopressors after we have fully fluid resuscitated a patient. So, we talked a little bit about fluids earlier and basically the main types of fluids that we have available, but we haven't talked about vasopressors yet. And vasopressors generally act on our different receptors in the body. So it's very important to know where each of these different receptors are, particularly the first set of 5 receptor types that we have here. You see that they're bolded, so these are things that I would want you to know for an exam and in practice. But generally, you have to think about where each of these receptors is working so that you can understand how the actual vasopressor works. So with vasopressors, we have the vasopressor receptors, more or less. We have alpha 1 and alpha 2, which generally we find in vascular smooth muscles, so basically our periphery and our vasculature. And whenever we activate these cause vasoconstriction. With beta 1 is primarily found on the heart. And whenever you activate beta 1, that increases your heart rate, or chronotropy, and increases your contraction, or inotropy, and it increases your conduction, also known as drumotropy. With your beta 2s, those are actually found on the lungs and the vascular smooth muscle. So the lungs, when they are activated there, cause bronchodilation, like you see with your beta 2 agonists like albuterol, salmeterol, etc. And in the vascular smooth muscle, they actually cause vasodilation, which is a little bit, what you would think is the opposite of what they would do, because you have your alpha receptors cause vasoconstriction. Well, in your periphery, your beta 2s actually cause vasodilation. So that's important to know, because we'll talk about an agent that actually causes an issue with this. We also have our vasopressin receptors, which are known as V1A and V2. There are other types of vasopressin receptors out there, but these are the main two that we're going to talk about for today. The V1As are in the vascular smooth muscle, and they cause vasoconstriction. The V2s are in the renal collecting duct, and they cause water reabsorption. Then we also have our dopamine receptors, D1 and D2. They're either found in coronary, renal, mesenteric, and cerebral beds, or in the vasculature and the kidneys. And this basically, when they are activated, will help promote renal and mesenteric perfusion, diuresis, and natriuresis. Again, it's important to know where each of these receptors are in the body and how they work whenever you agonize them. And that will basically help guide you in regards to what each of these pressors actually does. This basically is just a little bit of the pharmacological schematic of what each of these receptors does, at least in terms of alpha agonist and beta agonist. You don't need to know necessarily the large pathway here. Mainly, I want you to focus on what was on the last slide. I want you to basically know what receptor it binds to, and then I also want you to know what the net result is. So for alpha agonist, I want you to know that they bind to the alpha receptors like alpha 1, and they will cause vasoconstriction in the periphery. With beta agonist, I want you to know that they will more or less, for beta 1, cause positive chronotropy, positive inotropy, positive drumotropy, which you don't see here. And then for beta 2 agonists, they will also cause vasodilation in the periphery. That's basically all I want you to know. But this is basically how it gets to that point on a more physiological basis. So we have many different vasopressor options: norepinephrine, epinephrine, phenylephrine, dopamine, and vasopressin. And you've probably talked about this prior in your cardiology course, but we're going to talk a little bit about them again and review the basics of each of them. So norepinephrine is also known as Levofed. It is a mixed alpha and beta agonist. So whenever you think about the functions of our alpha and beta receptors, it will primarily work on the periphery, and it will also work on the heart. So we call this agent, or you can think of this agent as an inoconstrictor, because it's helping contract the heart and vasoconstrict. It has more action on the alpha 1 receptor than your general beta receptors. It's better at vasoconstriction or increased systemic vascular resistance. Your dosage ranges, I don't want you to know the dosages on these meds. You see that they're not bolded here. I just want you to know that they're titratable, and that you basically will titrate to a goal map, which will generally be greater than 65 many a time. I do want you to know, though, that a central line for administration is preferred with these agents, as they can extravasate very easily, or basically leave the bloodstream very easily and result in tissue necrosis. Generally, we usually like to inject or basically infuse norepinephrine into a large bore vein, and usually a central line can accomplish that. You can, for short periods of time, like few hours, administer lower doses of norepinephrine in a peripheral line, that's generally not preferred or not advised because you might get this nasty tissue necrosis happen. And if you don't get a central line in place, relatively quickly, the longer that you wait, the higher the risk of this is. And it can even happen in a short term if you're even infusing in a peripheral line. So usually try to get a central line if possible. But sometimes whenever you have a patient that comes into the hospital with shock, it's very difficult for that process to occur immediately where you get the central line immediately, because the central line, remember, is a procedure. You have to actually go in and insert that central line, and sometimes that takes a little bit of time. So adverse effects. So if you're activating beta-1 on the heart, remember you have one heart and you have two lungs. So beta-1 is on the heart, beta-2 is on the lungs. If you're activating beta-1, you're going to get dysrhythmias usually, or tachycardias, and you can actually see supraventricular tachycardia due to the beta-1 effect. So any of these meds that activate beta-1 is going to basically, predispose you to increasing heart rate and potentially increasing your risk of arrhythmias. Because of its alpha and beta contributions, it can cause hypertension, obviously. We're using this medication to treat shock. We can get peripheral or digit ischemia from this. What that basically means is if you clamp down too much on your vasculature, such that your vasculature is clamped so badly down that you are not getting much blood flow to your extremities, even though you're keeping your pressure up, can actually result in your digits or your fingers and toes becoming very nasty and very ischemic. And that ischemia or loss of oxygen can basically result in your fingers and toes becoming necrotic. And sometimes in patients who are on very high doses or very long doses, like days to weeks, sometimes patients may develop this digit ischemia and may actually have to have their digits potentially amputated, because those digits can become infected basically just from the fact that they become necrotic. And that can actually make things like sepsis worse. We don't want that. You can get reflex bradycardia from the fact that you may increase tachycardia, for example. Your body's response may be to become bradycardic. And like I mentioned earlier, central lines are important to minimize the risk of tissue necrosis with extravasation. We usually treat tissue extravasation with a lot of these vasopressor agents, particularly our alpha and beta receptor type agents with phentolamine, which is basically an antagonist of alpha. And it will basically cause vasodilation of that particular area where you may locally administrate that phentolamine to basically try to get the vasopressor back into the vein. Epinephrine is another alpha and beta agonist. It's very similar to norepinephrine, but there's more emphasis on the beta-1 receptor in this case. So there's more emphasis on the inotropy, chronotropy, dromotropy components compared to norepinephrine. But it's still an inoconstrictor because it does work very well in alpha also. Dosage ranges, again, are titratable in a lot of cases. Sometimes you might not necessarily titrate this. It depends on what the use of it is actually for. If it's being used for a distributive shock like septic shock or a cardiogenic shock. Cardiogenic shock, they may go a little bit slower. With epinephrine, you also need central line administration for the purpose of tissue necrosis. Epi can cause tachycardia, ventricular arrhythmias, hypertension, and digital ischemia, just like with norepinephrine. Phenylephrine or neosynephrine is different from epinephrine and norepinephrine in that it's just pure alpha-1. So think vasoconstrictor. It doesn't really have any beta activity. And as a result, it's only going to really increase systemic vascular resistance. It won't have necessarily any direct effects on the heart. You see the dosage ranges here. It's titrated to the goal map. Central IV line administration is preferred. may get reflex bradycardia from this agent because of the clamping down of the vasculature may slow down the heart a little bit. But there's not going to be any tachycardia generally with this agent. We may see hypertension, digit ischemia, and again, the tissue necrosis with extravasation. Dopamine is actually a very unique agent. It is dependent on the dose regarding its actual effects. So generally, it works on alpha 1, beta, and primarily D1, but there is some D2 agonism also, but the predominant action will depend on the dose. So at the low doses, and this range can actually vary, but depending on what resource you're looking at, generally though, in the low doses between 0.5 and 3, and these are the doses I want you to know for exam purposes, you may get D1 and D2 agonism, and that can increase your mesenteric and renal perfusion. That will basically help with your renal function in some cases, though in general there is data to suggest that this won't necessarily affect mortality or any of your greater outcomes. At doses of 3 to 10 micrograms per kilo per minute, you'll get beta 1 agonism predominantly, increased inotropy, chronotropy, geronotropy, more or less. And keep in mind that, at these different ranges, you're still going to have activities of each of the different receptors, but you're just going to have predominant effects at certain ranges. At doses of 10 to 20, you're going to have alpha 1 agonism, so increased systemic vascular resistance. Generally with this one, you don't want to titrate to effect because you want to aim for whatever the range is that you are trying to go for with your particular agent. So if you want to have beta agonism and alpha agonism, you might aim closer to the 10 mark because you'll basically get about, mostly beta 1 and alpha 1 agonism. If you want the renal effects and the mesenteric perfusion effects, you might aim for the lower doses. But generally, this is not an agent that's like the others where you just titrate it to effect, like norepinephrine, epinephrine, phenylephrine. Central administration is preferred, and you actually get similar things as you would with norepinephrine and epinephrine: tachycardia, ventricular arrhythmias, hypertension, digit ischemia, tissue necrosis. Vasopressin is also known as pitressin or vasostrict. It activates the V1A and the V2 receptors. Think of this one only as a vasoconstrictor, though. It does not bind to alpha or beta receptors, but it does bind to the V1A and the V2, which are in our periphery. And whenever that happens, you actually increase systemic vascular resistance by the vasoconstriction component. Generally, this one is set at a set dose. Usually, the dose is 0.03 units per minute IV continuous. In the case of sepsis, we don't titrate this dose, though you can actually go higher, all the way up to about 4 units per hour. And it depends on what usage you're using it for, but generally for sepsis, and this is a sepsis dose here, it's 0.03. You don't need to know this dose, but it's just something for you to be aware about. You don't titrate it. This can work very synergistically with other vasopressors because of its different mechanism of action. Usually, sometimes what happens in sepsis and septic shock is that patients become very endogenously vasopressin depleted. Keep in mind that all these vasopressors that we have listed here can be found in some form or fashion in your body already. And whenever you're septic, usually what happens is you kind of gas out at the beginning, or you basically hit the brake, or you hit the basically gas pedal at the beginning, which depletes a lot of your vasopressin because it's a fight or flight response in sepsis. Then eventually at some point your vasopressin might actually become depleted in your body. So this can kind of, provide a nice little kick. Vasopressin action is preserved during hypoxic and acidotic states that we see in sepsis and shock. Central line administration is preferred with this agent also being a vasopressor, and adverse effects are hypertension and digit ischemia. So this here actually compares all of the different vasopressor activities. You see here, all I want you to know, I don't want you to know necessarily each of the different amounts of pluses or whatnot. I do want you to keep in mind though what was on the slides and basically where they bind and approximately, do they bind better to alpha or do they bind better to beta? Is it a better alpha agent or is it a better beta agent? With epinephrine, we mentioned that, epinephrine generally does beta better, but depending on the source that you read, you may see 4 or 5 actual pluses with alpha. Just keep in mind that epinephrine is better at beta. Phenylephrine only alpha, as we mentioned, and then dopamine can basically be any of these 4 left receptors, depending on what your dose is. Vasopressin, like we mentioned, only binds to vasopressin receptors. How do we monitor vasopressors? Obviously, we want to look at the blood pressure. So in regards to patients who are on vasopressors, a lot of times they're put on it for a blood pressure related reason. We want to watch the heart rate. If the heart rate kind of starts spiraling out of control where it starts getting super high and you get a tachycardia or a supraventricular tachycardia of some type, that might be an indication for you to potentially change agents, or basically wean down one agent and start another agent. For example, like phenylephrine or vasopressin, which don't have any direct beta activity. Electrocardiograms are very important to monitor for those irregular rhythms. Urine output, remember those pressors are being used to increase our blood pressure in the body. And remember, our kidneys usually take a hit first because they have 25% of our cardiac output. So if we're increasing our blood pressure, hopefully we're going to start getting some more urine output, at least at the beginning. And sometimes that doesn't always happen. But hopefully we start seeing, some good response. CVP is another thing that we monitor. Remember, it's just a relative measure of volume in that, we can measure it from one point of time to another point of time. And if it improves, that means that our volume status may be improving, but it's not the only thing. Blood flow to extremities and pulses. So we might want to check to see if, our limbs are cold. Do we have pulses there? Is it good? And if you have them available, some other things that you can actually, use are systemic vascular resistance numbers, cardiac output, cardiac index numbers, SVO2 and SCVO2. SVO2 and SCVO2 are numbers that you can actually get off of a venous blood gas. For cardiac output and cardiac index, you can get them from a Swan-Ganz catheter, or you can actually get it from a machine called a flow track. And a flow track is a machine that will actually measure cardiac output, cardiac index, if you hook it to certain types of lines, like a central line. It's very, very high-tech technology. And they can actually produce measurements of systemic vascular resistance as well, or basically that clamp. So how does all of these pressors actually apply to what we need to know in regards to how they work? So in the sepsis bundles, usually we will try to apply vasopressors once we've adequately fluid resuscitated the patient. So adequate fluid resuscitation for sepsis is generally 30 mils per kilo of crystalloid, based off of generally your actual body weight. So usually this is part of our 6-hour bundle per the 2013 sepsis guidelines. How does it work with septic shock? So if a patient's hypotensive after their initial 30 mils per kilo of NS or LR crystalloid resuscitation, you can start vasopressor agents. The one with the most data associated with it is norepinephrine, and that's the one we usually use for first-line agent to target a MAP of greater than or equal to 65. Usually the second line that we recommend is vasopressin. It can be added to norepinephrine as a second-line vasopressor if the MAP goal cannot be attained by norepinephrine alone. The guidelines will then recommend epinephrine after that to be added on to doses of norepinephrine and vasopressin. If the patient is, not doing well and is still hypotensive on norepinephrine and vasopressin. Then you can also, have other strategies also of adding other agents on. Phenylephrine could be potentially added on as a third or fourth line agent, though the sepsis guidelines don't mention phenylephrine as a complete recommendation. A lot of times I do see it happen or to the point where it will actually be started after vasopressin, sometimes in place of epinephrine. But phenylephrine is also useful in patients that have tachycardias or tachyarrhythmias like supraventricular arrhythmias that can occur with norepinephrine or epinephrine because of the beta effect. If you think about phenylephrine, it only works on alpha, so the tachycardias and the tachyarrhythmias won't be as likely to happen. And dopamine is usually recommended last line as a result of what we talked about in the sepsis talk, that basically it's very pro-arrhythmic, and it kind of has a lower incidence, or has a lower affinity, for the alpha and beta receptors compared to some of our other agents that we have. It's good at all things, but it doesn't have like one thing that it's, predominantly best at. And that's kind of the way that I treat dopamine. I'll use it sometimes, if you have a patient that has like a bradycardia issue with their shock, dopamine can be used in those cases of niche bradycardia for whatever reason. But generally, it's recommended last line in the sepsis septic shock guidelines. Another agent that's come out within the last few years is called angiotensin II, or Giapreza. And this one doesn't necessarily have a formal guideline recommendation yet, but it does increase vasoconstriction and aldosterone release. So it basically does what is the opposite of our ACE inhibitors and our angiotensin receptor blockers like lisinopril or losartan. You can use this in sepsis and or basically septic shock or other distributive shocks that are refractory to vasopressor therapy. The dosage ranges come in nanograms per kilo per minute. Central line administration is required. It's expensive. It's thousands and thousands of dollars for this little vial here. And you can see things like tachycardia, hypertension, digit ischemia, and it also can increase risk of thrombotic events occurring. One unique thing with angiotensin II is that it is a new agent, but it actually works very quick. Within about 5 to 15 minutes, you can actually see a very, very strong blood pressure response to where you can actually wean off the other vasopressor agents. But at this time, it really hasn't found, a concrete place in practice. You may see it at some of your practice sites that you practice at, where it might have, very high amount of restrictions for use. In certain types of distributive shocks. I just want you to be aware that it is out there, and it is something, that's being kind of thought about in regards to its place in future therapy. But right now, not generally widespread, but it can be used. And I probably see a few patients every year that get treated with angiotensin II, related a lot of times to either a refractory septic shock or sometimes a result of anesthesia, which may cause distributive shocks also through vasodilation mechanisms. Last shock we'll talk about is cardiogenic shock and the different inotropic agents we have. So cardiogenic shock is the third shock, or our third main shock, and it's a result of ventricular failure. So this is a pump problem. So hypovolemic shock was a volume problem. Distributive shock was a vascular tone problem. Cardiogenic shock is a pump problem. So you're having a problem generating cardiac output, which, remember, blood pressure is governed by cardiac output and systemic vascular resistance. So where cardiogenic shock falls here is that if you have a low cardiac output, a lot of times due to a heart failure exacerbation or some other type of event, that low cardiac output will then increase your systemic vascular resistance as a compensation. And basically, that systemic vascular resistance is also known as your afterload. So it is more or less hard to overcome that afterload to pump out because your cardiac output is already so low that your vasculature has tried to compensate for that by clamping down. And as a result of that clamp down, you basically get a backflow of volume, which results in your elevated volumes like your CVP and your wedge pressure in your pulmonary arteries. Acute decompensated heart failure, as you know, and cardiogenic shock are very one and the same or one and similar. Anything that can cause acute decompensated heart failure can contribute to cardiogenic shock. So dietary indiscretion, like too much sodium or too much fluid in heart failure patients. Really bad NSAID use in patients who have pre-existing heart failure. Negative inotropic agents like dotiazine and verapamil, these agents do not help with cardiac output. They actually are negative inotropes. Those are not great. Medication non-adherence, if your patient has heart failure, infection, like we would see with sepsis. And if you have a sepsis patient with pre-existing heart failure, you can kind of get that hypodynamic septic shock we talked about earlier. Myocardial infarction, if you kill part of the heart, it will basically sometimes, depending on the extent that's killed, will cause the heart to not pump as well. Atrial or ventricular arrhythmias can happen as well with this. Hypertensive crisis, myocarditis, or an inflammation of the heart muscle. Acute valvular insufficiency, such that you might have stenosis or regurgitation occur, and if that valve is not able to, move that blood sufficiently forward because it's not able to open properly, that might cause a cardiogenic shock. And you might also see this with some symptomatic hypo or hyperthyroidism as well. So patient presentation, think about acute decompensated heart failure in regards to your subsets. So subset 1 through 4, where you have the warm and dry, the warm and wet, the cold and dry, and the cold and wet. Sometimes you can see fluid overload with these patients, so that can result in weight gain, can result in problems breathing, can result in jugular venous distension, more volume there, crackles, hepatomegaly, lower extremity edema, and extreme fatigue from obviously not being able to breathe and having to carry a whole bunch of fluid extra around. So that's one component of the patient presentation potentially that you may see. You may see obviously a low cardiac output with that, and with that comes hypotension, cool extremities. As a result of the hypotension, you get worsening renal function, which is also known as cardiorenal syndrome, basically a low cardiac output resulting in lower perfusion to the kidneys, is known as cardiorenal syndrome, and you see that a lot in patients who have chronic heart failure or chronic worsening heart failure. And worsening hepatic function also, because remember, cardiac output also contributes to our liver blood flow. We also might have organ hypoperfusion, so that can result in altered mental status, that can result in uncontrolled hypertension, and it can also result in an MI if we don't have enough oxygen getting to certain places. So like we said, we want to think about our subsets whenever we are generally thinking about how we treat cardiogenic shock, because a lot of times it will mostly have some type of heart failure component to it in many cases, but that's not always the case. It might be an acute event. So usually what we want to think about with cardiogenic shock is basically the subset 3 and subset 4 that we see here from your DePiro book. In regards to pharmacotherapy, there are many different pharmacotherapies that can be used to treat acute decompensated heart failure and as a result cardiogenic shock. Loop diuretics and thiazide diuretics are used basically to diurese. Loop diuretics being the primary source of diuresis, thiazide and thiazide-like diuretics being an adjunct to loops, where you can basically give those agents 30 minutes before a loop. Vasodilators, if your blood pressure is sufficient, like nitroglycerin and nitroprusside. Desertide is actually not made anymore, and that's why it is not on this list. But the main agents that we're going to talk about are the inotropes, which are dobutamine and milrinone. Dobutamine is primarily a beta-1 and beta-2 agonist with minimal alpha activity. So whenever you think dobutamine, think just beta-1 and beta-2. As a result of activating beta-1, it produces inotropy, chronotropy, and dromotropy. Remember, one heart is where you find that 1 beta, beta-1. It has a short half-life. Its dosing is potentially titratable. Sometimes you may not titrate it, though. It just depends on what you clinically see. Sometimes if patients are getting worse, then you'll titrate it up. Central line administration is preferred with this agent, similar to our vasopressor agents, though dobutamine is not a vasopressor agent. We more consider this to be what is known as an inodilator. Because it activates beta-2 in the periphery, that beta-2 in the periphery actually causes vasodilation. And that's actually how we get hypotension. is basically from that beta 2 component. And that's basically why we call it an inodilator, because it activates beta 1, which will contract the heart, and beta 2 in the periphery, which will vasodilate. Because it does activate beta 1, though, like a lot of our other pressor agents or vasoactive agents, you see tachycardia and ventricular arrhythmias from this, and you can also see tissue necrosis with extravasation. Treat with ventolamine, just like the other ones we talked about. Milrinone is a phosphodiesterase 3 inhibitor, which is different than the other agents we talked about that are either vasopressin agonist or alpha-beta agonist. Milrinone increases inotropy, chronotropy, and dromotropy also. It has a little bit longer of a half-life, and the dosing is different, as you'll see here. The renal component of it can be problematic in renal patients in regards to its elimination. So if you have a patient who has kidney dysfunction, like AKI, CKD, end-stage renal disease, you might have to watch what doses you start them out on. You might want to start them at a lower dose of this agent if you need to. But with milrinone in general, what we're usually concerned about is the tachycardia, ventricular arrhythmia component, and hypotension. Those are the two main things that we're generally concerned about. And basically this mechanism here kind of shows you more or less how this process works a little bit in regards to the phosphodiesterase inhibitors pharmacologically, physiologically. So we talked basically about that second half. And that's basically where we kind of want to focus on. So if you're cold and dry, you obviously want to assess the volume status. And we want to obviously know about our cutoff numbers for cardiac index, which is 2.2. Being below 2.2 is bad. That's what makes us cold. And then 18. If you're above 18, you're wet. If you are below 18 significantly, you are dry, particularly if you're less than 15. If you're less than 15, that usually means that you need IV fluids. But if you are in subset 3 and you are 15 to 18, then you have to assess basically the blood pressure. If your blood pressure is good, we use vasodilators in these cases. Always use a vasodilator first. If you have a good blood pressure, is generally the rule of thumb with this algorithm. If you have a bad blood pressure where the systolic is less than 90 or the MAP is less than 65, then we'll want to give an IV inotrope, such as dopamine or milrinone. Same concepts with cold and wet, except that we're going to give, obviously, diuretics to these patients because they are wet. If you have a good blood pressure, you'll do that with a vasodilator. If you have bad blood pressure, you'll do that with an inotrope, or basically milrinone or dopamine. So this basically just summarizes what we just talked about. Cold and dry, you usually want to give your vasodilator first. They're preferred. But if you have a patient with systolic less than 90 or a MAP less than 65, you'll want to give an inotropic agent. And if your patient for some reason has hypovolemia because they're too dry, you want to give IV fluids first. Don't give any diuretic therapy and don't give any vasodilators yet. Give the fluid first and then reassess where they are at in your subset. Subset 4. Just what we talked about on the previous slides. Basically, you treat the wet part with diuretics generally, loops being first line. If your blood pressure is good, you do that with a vasodilator like nitroglycerin, nitroprusside. If your systolic or your MAP is bad, you're going to do an inotrope. Because basically those vasodilators are going to lower your blood pressure much faster than an inotrope would. So keep in mind the differences in where you're doing this. Subset 3 and subset 4 heart failure are basically more or less subsets of cardiogenic shock. Additionally, the last part that we'll talk about is MCS, or mechanical circulatory support. So this results whenever you basically tried a whole bunch of things, and you might have tried inotropes, you might have tried multiple inotropes, you might have tried multiple, diuretics. You just have really, really bad, like stage 4 heart failure, and basically you need something that is not a med to help that heart pump. And there are actually devices called mechanical circulatory support, or mechanical circulatory devices, more or less, that help with that. Our main ones are intra-aortic balloon pump, ventricular assist devices, and ECMO, also known with this subset as VA ECMO. More commonly than not, you'll see these three in practice. An intra-aortic balloon pump is a balloon that basically gets inflated within the aorta to basically expand it out so that the heart can actually expel blood. Ventricular assist devices are actually what you see here. They're also known as LVADs, or left ventricular assist devices, if they help the left ventricular pump. Left ventricle pump, my apologies, or RVAD, right ventricular assist device, if it helps the right ventricle pump. There are many different devices that are out there, like HeartMate 2, HeartMate 3, Levotronics, Tandem Heart. These are some names that you might see out there in practice that are VADs. Some of these VADs actually may have special requirements associated with them. Some of them may be only inpatient VADs, like Impellas. Some of them may be outpatient VADs, like HeartMate 2s. I don't necessarily want you to know the names of these, but I do want you to be aware of the fact that these VADs sometimes, because they disrupt blood flow to an extent in the way that they help the heart pump blood, they actually can increase risk of clotting. And as a result, patients may have to be on anticoagulation with some of these VAD agents. Primarily, if you're on the inpatient side and you need an IV continuous infusion of something, generally it's going to be heparin that's used on a lot of these VADs. There are some exceptions to that, though. With outpatient management, generally a lot of these patients will be on warfarin, as it's basically the most looked at drug with these devices. Additionally, you may use VA ECMO for some of these patients, especially if they're very, very bad off in the hospital. Remember, VA ECMO will help with the respiratory status and the cardiac status. Here are the references for today's talk. And if you have any questions regarding fluids, vasoactive agents, and shock syndromes, please feel free to email me or contact me. Thank you and have a great day.